Good evening and welcome to UT Southwestern's Science Cafe. We welcome both our regulars and our new guests to this ongoing series. The UT Southwestern Public Affairs team is so proud to produce this series. In fact, this Saturday, we will celebrate our 2-year anniversary of the program. We hosted our very first Science Cafe on April 30th, 2020, with Dr. Stu Ravnick speaking on brain teasers, science creativity, and the power of observation. My name is Charlondra Thompson, and I'm a member of the Public Affairs team at UT Southwestern. On behalf of my colleagues, Jenny King and Joya Lang, as well as our guest speakers, Dr. Chika Nwachukwu and Dr. Luke Engelking, thank you for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dives into science and healthcare topics. At UT Southwestern, we're an academic medical center, which means we bring together research, medical and health education, and patient care into one institution. The research and education informs care advancements quickly, which is a benefit to our patients and the broader community. We have fun at Science Cafes while we learn and engage during the program via the chat and the audience Q&A. This evening, we are discussing minority cancer awareness with Dr. Chika Nwachukwu and Dr. Luke Engelking. More on them in just a moment. Before we begin, let me share a few technical points. We are recording this program and live streaming it on UT Southwestern's Twitter page. Please mute your microphones to help with audio clarity for everyone. Also, we encourage you to leave your video on so we can see our Science Cafe community, especially during the Q&A portion of our program. Finally, just a reminder, while we cannot answer personal medical questions, we would love to hear from you with general questions on the topic of minority cancer research. And with that, I'm pleased to introduce our guest speakers. Dr. Chika Nwachukwu is an assistant professor of radiology oncology at UT Southwestern Medical Center. Dr. Nwachukwu's focus is on both breast and gynecologic cancers. Dr. Luke Engelking is an assistant professor of internal medicine at UT Southwestern Medical Center and a member of its Division of Digestive and Liver Diseases. Dr. Nwachukwu and Dr. Engelking, thank you for joining us this evening. Welcome to the Science Cafe. Dr. Nwachukwu, the live virtual podium is yours.
Great, thank you for that introduction. I'm gonna attempt to share my screen. Thank you for that kind introduction, and thank you for everyone who joined tonight. Tonight, I'm going to talk a little bit about disparities in breast and cervical cancers. I'm going to discuss the problems and potential solutions. Here's the outline of my talk. I'm just going to give some general numbers about health disparities. I'm going to talk about some contributors to health disparities. I'm going to try and use breast cancer as an example to discuss how nature can contribute to our health disparities, and use cervical cancer as an example of how nurture contributes to health disparities. I'm going to talk about some interventions and next steps. So Joya, if you can launch the first question. Okay, interesting numbers here. You'll see the answer in a couple of slides. Let's see if we can you guys see the results? Yes, okay. Stop this one. So I'll show you the answer in a couple of slides, but those are some interesting results. So cancer is in fact a global problem. The International Agency for Cancer Research estimates that about 1 in 5 people will develop cancer in their lifetime. And that equates to about 1 in 8 men dying from cancer and about 1 in 11 women dying from cancer. And so we now know that cancer has killed more people than HIV, TB, and malaria combined. And so whenever you have such an impactful, something that impacts a significant proportion of people, there are bound to be some disparities associated with it. So if we delve deeper into the United States, so the answer to the question is the Asians, and you can see the numbers here. But if we delve specifically into the US, and you can see in terms of incidence of cancer, majority of cancers are more common in white patients, and that's in close proximity to Black patients, Hispanic patients, Asian Pacific Islanders, and then American Indian and Alaskan Natives. However, when we look at the mortality or death rates from cancer, you can see that the highest proportion is in Black patients. And you can also see the numbers in other minority populations are pretty high. When we look specifically by cancers that we have screening methods for, you can see that the general trend, these are mortality rates amongst cancers that we do have screening recommendations for. You can see that the general trend is that there are higher rates of mortality in Black patients, for example, in Black patients with lung, prostate, colorectal cancers. You can see there are higher rates of mortality in Alaskan Natives and American Indians with liver cancers, and similar trends in female cancers. And so one reason why this may be this may be the case is that for cancers where we have screening recommendations, there happens to be lower proportion of localized diseases. And so the thought is that if we have screening recommendations for a particular cancer, you should be able to catch that cancer when it's at an earlier localized stage. But there happens to be lower proportions of localized stage disease, or in contrast, or in converse, higher proportions of advanced stage disease in minorities. And that can translate into the higher mortality that you see on this slide. And so what are some of these factors that contribute to these disparities? We know that there's a significant interplay between nature, which is essentially your genetic makeup, the genes that are passed down from families to mother and father to children, with nurture. And nurture essentially has to do with the risk factors and prevention, risk factors, access to prevention and screening guidelines, access to adequate treatments. And all of these things are rooted in social determinants of health. And your social determinants of health are essentially where you live, where you grow up, where you work. And all of these are affected by larger social economic policies. And all of these factors can affect positively or negatively affect cancer occurrences in populations. So I'm going to spend some time just explaining, using breast cancer as an example to show how nature can account for cancer disparities. So here again, I like this figure, even though it's an older figure. You can see the numbers from 1975 to about 2005. It shows you the trends in female breast cancer incidence. Again, this is kind of mirroring what I showed earlier in the general population, that you have the highest incidence of breast cancer in white women. And you can see the numbers here in African-American women. And you can see when we start to track breast cancer in other minority populations. And so although the incidence is highest in white women, you can see that the mortality rates are the highest in Black women. And the American, Indian, Alaska Native mortality rates are coming closer, rivaling that of white women. So this is interesting. This is older data. And so where have we come now in recent times? You can see that the numbers, even though the gaps are closing, the numbers remain the same, and the trends are still pretty much the same. The rates of cancer death are much higher amongst Black women, and Native American and Alaskan Natives rival that of white women in 2019. And so the gaps are closing, but they're not totally closed yet. And so the question is, why are we still having these disparities? And I want to use breast cancer to sort of describe why these disparities are occurring. So here's the next question. Great, I love it. Everyone knows the risk factors for breast cancer. Fantastic. Oh, I should reiterate that the question says, which is not a well-known risk factor. Okay, great. So majority of people know that all of these factors are risk factors for developing breast cancer. Let's see if we can go to the next slide. And so there are lots of risk factors for breast cancers. One of the most commonly well-known ones is a family history, and family history is a heterogeneous risk factor for breast cancer, and it depends on how many individuals in the family, first or second degree relatives. So it's a heterogeneous risk factor, but there are many more risk factors. And so the recommendation is that patients start mammography screening at age 45, and even much earlier if you have a family history of breast cancer. In addition to a family history of breast cancer, there are also hereditary risk factors. And so here is a list, not an exhaustive list by any means, but a list of genes that are associated with breast cancer. And by far the most common hereditary associated genes are BRCA1 and BRCA2. And they are associated with the development of breast cancer in approximately 60% of cases. And so what the reason I'm showing this slide is essentially that when a patient is diagnosed with breast cancer, these patients are seen in the genetics clinic to determine whether or not they meet criteria to have genetic testing. The great thing about genetic testing is that it's more widely available now. It's definitely better covered by insurance, and it allows for us to determine if patients have any of the genetic contributions that you're seeing here. And this can inform the risk of developing breast cancers, as well as other cancers, and allow for risk reducing interventions for patients and their families. And so although you can't really modify your hereditary factors, there are risk reducing interventions that we can use to decrease morbidity. So for us to really understand how your genetics can contribute to disparities, we have to take just a small deep dive into understanding the biology of breast cancers. So we've known for a really long time that breast cancers are not one disease. And we know based on gene expression profiling that we can categorize breast cancers into these 5 major subtypes. And so they're basal-like, HER2, normal-like, luminal B, and luminal A. And these 5 subtypes of breast cancers are associated with outcomes. And so what you can see on these graphs on the right side of the screen is that the basal-like and HER2 subtypes are associated with the worst prognosis. Note that this study was published before Herceptin was used for treatment in patients with HER2 positive breast cancer. So if we were to repeat this graph in the age of Herceptin, this pink line would be higher up here. And essentially what this slide, the point I'm driving home with this is that the basal-like tumors have the worst outcomes. And so to understand what this means, we have to understand how we clinically define breast cancers. And so we clinically define them by expression of the hormone receptor, either estrogen or progesterone, as well as the expression of the HER2 gene. And so the point is that the basal-like subtypes are, quote, known as triple negative tumors because they don't express ER, PR, or HER2. And so we classify them as triple negative tumors. And the reason why this is important is that we don't have targeted therapies for these tumors. And so why is this important? Triple negative tumors are often diagnosed in younger patients. And as I just mentioned, the American Cancer Society recommends that we start screening at age 45. And so typically, if this cancer subtype is occurring in younger patients, early detection is not feasible for these patients. These tumors are also have aggressive pathologic features, and they often can present as interval cancers. And so that means even for women who are in the screening age group, the triple negative tumors tend to present between their screening mammographies. And these tumors can be deadly. There is early recurrence. And because we don't have molecular targeted therapies for these tumors, they can be associated with increased morbidity from breast cancer. So how does this tie into disparities? What you can see from this study is that these basal-like as I just mentioned, the basal-like or triple-negative breast cancers are overrepresented in Black populations. And so this is one example of how genetics contributes to our genetics can contribute to mortality, hence leading to the disparities that we're seeing in the death rates of African-American patients, for example. So what do we need to do? The answer is to identify potential therapeutic targets for triple-negative tumors. And so that's what researchers are currently looking at now. Again, this is not an exhaustive list, but there are different pathways that we need to try and identify so that we can identify therapies for patients with triple-negative breast cancers. For us to be able to do that, though, it means that we need to diversify our studies of understanding genomic. We need to understand better genomic diversity in our populations. In 2021, it was reported that all genomic studies were conducted from about 80% of patients of European ancestry, and so you can see that it presents a challenge to try and understand the genetic markers that predispose patients to the types of tumors they have based on their ethnicities. So how do we solve this problem? Lots of different stakeholders, including community researchers. We have to think about diverse strategic funding mechanisms. We have to take advantage of infrastructure, so including computing and biorepositories. There has to be capacity building using leadership and bioinformatics. And there has to be a diverse patient population in these studies. And so these are all things that the UT Southwestern is currently working on for breast cancer. So I hope I've been able to sort of give you a sense of how your genetics can play a role in cancer mortality and in disparities for breast cancer. So I'm going to quickly switch gears and talk about how nurture can be a factor for disparities we see in cervical cancer. And so here's another question. Okay, great. That's pretty good. So a lot of people think 14,000 and a good proportion think 100,000. So I would say that the answer is most people got the right answer. So cervical cancer in the United States makes up a smaller percentage of all cancers that are diagnosed. So there are about 14,000 new cases in the US, but note that the worldwide burden of cervical cancer is in the 500,000 range. So cervical cancers, majority of them are as a result of persistent infection with the HPV virus. And what you can see here is that most patients who have an HPV infection will clear the HPV infection, but then there are some patients who are unable to clear this infection and so can progress to cervical cancer. And here are some of the factors that are associated with persistent infection in patients. And so the reason why cervical cancer is important to me is there are multiple reasons, but two in my mind are clear. One is that it is one of the most preventable cancers. In the advent of screening and the HPV vaccine, we can prevent all cervical cancers if we tried really hard. And the number two reason is that it continues to be the leading cause of death amongst women in the 20 to 30 years of age. And so essentially, you're losing women who potentially have significant life to live and significant contributions to make to society. So I think it's very important, even though it's a smaller percentage in the US. So just the last question we have here, what's the recommended age for patients to receive the HPV vaccine? Okay, great. So that you are absolutely right. The recommendations used to be 9 to 12, but recently the recommendations have been updated. And so see if I can advance the slides. Recommendations have been updated so that the vaccine can be received from age 9 and up to 45. The reason, again, I present this is to show that the vaccine rates in the US in general are low, about 51%. There are multiple vaccines that have been approved by the FDA, but the vaccine rates are much lower amongst minority populations. In addition, screening and testing for HPV, which should begin at age 25, is much lower again in minority patients. And so what does that mean? Essentially, it leads to this these disparities that we see in terms of incidence in the patients who are diagnosed with cervical cancer. And so you can see here that minority populations have the highest incidence of cervical cancer, and similarly, they have the highest death rates of cervical cancer. How about cervical cancer in Dallas? When we compare cervical cancer to the general US population, the numbers are much higher. And you can see here, again, as I mentioned, majority of the minority populations have bear the burden of cervical cancer in Dallas. And so the majority of the patients that I see and that I treat are minority patients. So they're either Black or Hispanic patients, and they present at an advanced stage. Their disease presents at a much advanced stage, and that's because they're either have live in poverty, limited access to education, access to care, they're underinsured or uninsured. And so what are we doing about this at UT Southwestern? The American Society for Cytology and Cervical Pathology essentially has outlined risk management consensus guidelines for patients who have abnormal screening tests. And so this is a slide from Dr. Tiro. Her group, she leads the Prosper Metrics group, and essentially one of their main goals is to try and connect patients, these vulnerable populations, connect them into the system to ensure that patients who have abnormal screening results don't fall out of the system, and they're able to get adequate care. What are we doing from the intervention standpoint? So one of the things that I'm really interested in, and one of the things that I care about, is understanding the biology of cervical cancer in this patient population. And so we're collecting samples for every cervical cancer patient to better understand their genetic makeup with the hopes of developing targeted therapies. We're designing clinical trials to try and minimize the burden of treatments on these patients. And then we're also encouraging all of our patients to have their families receive the HPV vaccine and also promote screening amongst family members. And so what do we do? What's the future here? Again, the cure to cancer is prevention, but in the absence of prevention, in the face of having cancers, we have to try and understand the tumor biology of the patients we see in clinic. We have to develop biomarkers to help tailor their therapy, and we have to screen for effective agents so that we can design targeted therapy trials. Essentially, we have to take advantage of the resources we have. So like I mentioned, prevention is critical. Early detection, for early detection, as well as for cancer interception. Mammography screening can start at 40. Earlier, if your risk is higher, we want to try and help increase the HPV vaccine uptake and increase HPV testing and Pap testing. Again, we want to understand the biology, knowing that one size doesn't fit all, and so that we can properly address the cancer in the patient populations that we see. We want to tailor our therapies and, as I mentioned, design targeted therapy trials. And that's all I have for today.
The subject of my talk today is hereditary colon cancer, specifically the most important form of hereditary colon cancer, Lynch syndrome, and racial disparities in the evaluation of colon cancer and of Lynch syndrome itself. So I have nothing to disclose financially. So if you remember nothing else from my talk, I want you to remember three things. Now, don't worry, you don't have to remember them yet, because I'm going to show you these things again at the end. Okay, so first of all, you should think about getting colon cancer screening in your life. And the new age for starting colon cancer screening is age 45. It used to be 50. And this is the most important thing that you can do in your life to detect colon cancer early and actually prevent colon cancers in your life. So colonoscopy or other forms of colon cancer screening are extremely important. Second, if you have a personal, meaning yourself, or a family history, meaning of one of your close relatives, of either colon or endometrial cancer, you need to ask your doctor about Lynch syndrome and find out whether or not you need to undergo genetic testing for Lynch syndrome, this very severe syndrome that I'm going to be discussing. And lastly, unfortunately, it's true that there are racial and ethnic disparities in colorectal cancer in the US, even in Texas, even here in DFW. The causes are complex, but UT Southwestern is working on the solutions. So just a brief outline of my talk. To echo a lot of the themes from the first presentation, I'm going to give a brief conceptual framework about the ideas about health equities and health disparities. Then we're going to talk about Lynch syndrome, and then we're going to bring these two together and talk about healthcare disparities in Lynch syndrome itself. So first, healthcare equity and disparity. So what does health equity mean? This means that every person has an equal opportunity to attain his or her full health potential, and that no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And health disparities or health inequities are unfair health differences that are closely linked with social, economic, or environmental disadvantages that adversely affect certain groups, meaning certain racial or ethnic groups of people. So, how are these health disparities formed? Well, it's thought that they're formed because of social determinants of health. So the social determinants of health, when they disadvantage certain groups of people, lead to health disparities. So what are these social determinants of health? Again, this is another definition from the CDC, excuse me. Social determinants of health are conditions in the environments in which people are born, learn, live, love, work, play, worship, and grow old that affect a wide range of health, functioning, and quality of life measures. Social, economic, and physical conditions in these various environments affect quality of life and can affect populations' outcomes. Examples of these factors would be access to and quality in education, in healthcare, in employment, access to healthy food, access to safe and affordable housing, public safety. Now, it's the unfortunate truth that in our society, these social determinants of health are unequally distributed across our society, and these are important factors that are driving these racial and ethnic health disparities that we see. So I borrowed this slide from the Asthma and Allergy Foundation of America, who came up with this conceptual framework for the root causes of racial disparities in asthma. But I think this is a framework that really can work for a number of diseases, and certainly works in the case of colon cancer. So the idea is that racial and ethnic disparities in health outcomes are caused by a number of complex factors that are all acting in this continuum, and then are formed of a number of upstream factors. That these are things like structural determinants, such as both ongoing and the lingering effects of past racism, discrimination, and segregation in our society, along with the social and economic factors that I described in the last slide. These act through individual factors, such as an individual's genes and ancestry, and perhaps an individual's habits, such as diet, cigarette smoking, adherence to medical advice. And this is all acting together to create these health disparities that we see in our society. And so what do we do about it? These are obviously very, very difficult questions to answer, and there's no one simple solution. At the end, I will show you one example of how UT Southwestern is attacking this problem specifically in the area of Lynch syndrome. So, as I said, most of this talk is about colorectal cancer. So that's cancer of the colon or the rectum, which is simply just the end of the colon. So colorectal cancer is really a huge problem. It's the third most common cancer and the third most common cause of cancer death in both men and women in the US. Altogether, it causes about 150,000 cases a year and 50,000 deaths. So this is really a big problem. So not only is colon cancer a big problem, but there are big problems with racial disparities in colon cancer. So what we have plotted here are just age-adjusted rates of colon cancer and deaths from colon cancer in different in different racial and ethnic groups. And what you can see is that compared to the average, which is here in the blue, Blacks have about a 25% increased incidence of colon cancer, and unfortunately a 40% increase in mortality from colon cancer. Non-Hispanic Asians and Pacific Islanders and Hispanic people seem to be somewhat protected from colon cancer, and white people have a very close to the average incidence and mortality from colon cancer. So, what are the causes of the major disparity that we can see here, which is the fact that colon cancer is a much more severe disease in Black people? Well, it's likely multifactorial. One factor that's been brought up for colon cancer for many, many years is that perhaps there are reduced rates of colon cancer screening in Blacks compared to whites in the US. And so with that, let's pivot a moment to the issue of colon cancer screening. So this is one of the slides that I think is really important that I want you to remember. Not every single word on the slide, but just the general principle, which is that it's very important to undergo colon cancer screening in your life. I'm a gastroenterologist. We're the guys that do colonoscopies. In my opinion, far and away, the most important job of a gastroenterologist is to perform colon cancer screening. And we do that so that we can, number one, detect colon cancers at an early stage so that they can be easily treated. And number two, actually find and remove early cancers and precancerous lesions so that your chance of developing colon cancer is greatly reduced in your life. So how do we go about colon cancer screening? Well, we can look at the colon with a camera, like with colonoscopy. This is this test that I mentioned already. There's an abbreviated version of colonoscopy called sigmoidoscopy. There's a CAT scan version of colonoscopy called CT colonography. There are non-invasive tests that can be done as well. We can either test the stool for blood or for tumor DNA. It doesn't really matter how you do colon cancer screening. It's just important that you do it because these are all, at the end of the day, very good tests. As a gastroenterologist, I prefer colonoscopy, but that's just because I'm a gastroenterologist and that's what I do. The important issue is, when do we begin colon cancer screening? For many, many years, we said that it was at 50 years of age. So at 50, you had to undergo your colonoscopy or you had to start doing annual tests, annual stool blood tests with your primary care doctor. Over the last couple of decades, there's been a very concerning increase in colon cancer of the young, meaning colon cancer in people under the age of 50. So really in the last couple of years, we've dropped this starting age to 45. So if you remember nothing else from my session, please remember at the age of 45, you need to start thinking about entering into a colon cancer screening program to reduce your risk of developing colon cancer in your life. Okay. Now, back to healthcare disparities. As I mentioned, it was been thought for a long time that the reason why the incidence and the mortality of colon cancer in Blacks compared to whites was much worse was because of a reduced rate of colon cancer screenings in Blacks versus whites. And decades ago, that was true. You can see in the year 2000, compared to the red line, which is whites, in Blacks, there was about a 25% reduction in rates of screening for colon cancer. And this likely was a big contributor to racial disparities in colon cancer in the past. But what you can see is, happily over the last 2 decades, across all demographics, rates of colon cancer screening have really gone up quite a lot, such that this gap between whites and Blacks is now nearly closed. So despite the fact that this gap in colon cancer screening is closing, we still see these large disparities. So obviously there's other factors that are involved, whether they are biological factors related to the tumors of Blacks versus whites, or if they're the social and economic factors that I mentioned earlier in the talk. It's simply not known, and it's an area in active research. So moving on. So we're going to go from talking about colon cancer in general to a very specific form of colon cancer, a hereditary form of colon cancer called Lynch syndrome. So what does hereditary colon cancer mean? So a hereditary cancer is a cancer that clusters in a family, and it goes beyond familial cancer. So in familial cancer, that's an example where perhaps a grandparent and then years later, a grandchild developed the same cancer. That's actually very common. That might even happen in most families. And that it is an important risk factor for the development of certain cancers. In the case of colon cancer, if there's a close family history of colon cancer, your personal risk of developing colon cancer can be almost twofold increased. That's not what I'm talking about here. What I'm talking about with hereditary cancers, these are cancers that develop due to a gene mutation that a person is born with. And this gene mutation is passed from parent to child. This gene mutation causes a very large increase in your risk for cancer, even up to, for example, an 80% risk for developing colon cancer and Lynch syndrome, which I'll discuss shortly. And so furthermore, most of these hereditary cancer syndromes have what's called a dominant mode of inheritance. That means that if your parent had it, one of your parents had it, you have a 50% chance of having it. And furthermore, you have a 50% chance of passing it along to your children. So this is really a very big problem. So how common is it? So 70% of colon cancers are sporadic, meaning that they're not associated with any close family history, any sort of disease that can cause colon cancer, or any of these hereditary syndromes. It's thought that these sporadic cancers are caused really by something in the environment, whether it's diet, whether it's a personal habit like smoking or consuming alcohol. That's how these are formed. In 20% of colon cancers, there's a close family history, but not the hereditary forms, which constitute most of the remaining 10%. So of these hereditary forms, far and away the most common and so therefore the most important is Lynch syndrome, which is the focus of the remainder of the talk. So what is Lynch syndrome? It's the most common inherited form of colorectal cancer susceptibility. So here's the answer to the poll questions. So the people that guessed 1 in 300, you guys had it. The prevalence of Lynch syndrome is thought to be 1 in 300 people. And unfortunately, 95% of people with Lynch syndrome are unaware of their diagnosis. So in other words, only 5% of people that have Lynch syndrome know about it. And that's really why I'm giving this talk and telling you about Lynch syndrome, is because this is a syndrome that is really severe. You have an extremely high risk for developing colon or uterine cancer. It's really quite common amongst these rare genetic syndromes, and nearly no one that has it knows about it. As I mentioned, it accounts for 5% of the total colon cancer burden. This is a syndrome that's caused by mutations in one of 5 genes: MLH1, MSH2, MSH6, PMS2, or EpCAM, which are genes that are involved in DNA repair. So, as I've mentioned a couple of times now, Lynch syndrome is a syndrome in which there is very high risk for developing colon cancer, as high as 80% in your lifetime. There's also a very elevated risk for developing uterine cancer, as high as 60%. In addition to cancer in these 2 sites, there's an increased risk for developing cancer in other sites, such as the stomach, the pancreas, the urinary system, the prostate, the skin, which missed this slide from Utah. And so what I do in hereditary colon cancer clinic is I undertake whole body cancer screening of patients with Lynch syndrome. And so what does that mean? That means that these patients need to have a colonoscopy nearly every year, if not every 2 years, to screen them to ensure that if they develop colon cancer, we detect it early, and also to reduce their risk for developing colon cancer by removing early cancers and precancerous lesions. For the uterine cancer, it's recommended that as soon as a woman is through with childbearing, she undergo a hysterectomy to reduce her risk for developing uterine cancer. For these other cancers, on an individual basis, there may be other cancer screenings that are needed. And that's what I do in hereditary colon cancer clinic. So how do you find Lynch syndrome? Unfortunately, most of the time Lynch syndrome is found is found in a tumor. And so that's not the most ideal way for us to figure this out. For you to first have to develop cancer for us to figure out that you actually have Lynch syndrome. Okay, so as I mentioned a couple slides ago, tumors form in Lynch patients because of mutations in one of these 5 genes that are needed for DNA repair. Here in this example, MLH1 and PMS2. So this is a tissue slide of a colon tumor and surrounding normal tissue. It's been stained with 2 colors: blue, which colors all of the cells in the tissue, and brown, which picks up either the MLH1 or the PMS2 gene. So you'll have to take my word for it, but in this slide, the top part is where the tumor is, and the bottom part is the surrounding normal tissue. And you can appreciate, and in the top part where the tumor is, there's no brown, it's just blue. So that means that MLH1 and PMS1 are missing. So this is consistent with the diagnosis of Lynch syndrome. And this is in fact how Lynch syndrome is picked up most of the time. So you'll notice I said consistent with Lynch syndrome and not diagnostic of Lynch syndrome. And that's because confirmatory testing is required, okay? Because there is a chance that sporadic cancers as well can have this pattern of an absence of these Lynch syndrome proteins. And so the type of confirmatory testing that's needed is genetic testing. And so to undertake genetic testing, you have to be referred to a genetic counselor. A genetic counselor, seen here, will talk with you about your personal and your family history, and if appropriate, they will request very complex DNA testing, ideally both of the tumor and of the blood, to check for mutations in cancer risk genes, including these Lynch syndrome susceptibility genes. These are the possible outcomes of this testing. You can find a mutation in the germline, meaning in the blood, of these Lynch proteins. This would confirm a diagnosis of Lynch syndrome. In this case, further care for Lynch syndrome is needed, including a referral with a doctor that may be a specialist in this, like this handsome guy. Look how much hair he had in 2013. The other possible scenario is that no mutations are found in the germline, meaning in the blood, but mutations are simply found in the tumor. And this would be consistent with a sporadic cancer. And so no further care for Lynch syndrome is then needed. Okay. So taking these 2 subjects together in my last few talks, and let's talk about racial disparities in screening for Lynch syndrome and what UT Southwestern is doing to fix the situation. So as I mentioned, in the last scenario that I went through, you had to get cancer to find out that you have Lynch syndrome, which obviously is not a very good way to do it. Okay, so as it turns out, there are clinical guidelines to help us identify people that could have Lynch syndrome before they actually develop cancer. Now, unfortunately, these guidelines are extremely complex, so I don't want you to read through every single line. Let's just focus on the general principles. Okay, so in these first 2 criteria, basically the idea is that you yourself have a tumor that could be a Lynch tumor, really meaning a colon or an endometrial cancer. Okay. Also, if you have a family member that has Lynch syndrome, that is an indication to undergo genetic testing for Lynch syndrome, because if you recall, if you have a first-degree relative with Lynch syndrome, your own risk of having Lynch syndrome is 50%, which is very high enough that you should undergo testing. Also, if you have a family history, essentially all these criteria are a family history of bad colorectal or endometrial cancer, either because it happened very early or because it happened over and over in your family. Lastly, because these criteria are so complex, in the last few years, people have just come up with apps to take all this personal and family history together and to develop risk scores for Lynch syndrome. So also, there's these computational predictive models that can also be used to determine what your risk for having Lynch syndrome is. Basically, if you have any of these criteria, you need to undergo genetic testing for Lynch syndrome. Okay. And so a good friend of mine, Sonia Kupfer at University of Chicago, she became interested in how frequently does that happen. So how frequently do we identify people that could have Lynch syndrome, that we then refer them and get them genetic testing to confirm or refute whether they do have Lynch syndrome. Here she looked at a population of about 100,000 patients across the US who underwent health interviews. And they identified about 2,000 patients out of this 100,000 that had criteria for Lynch syndrome, one of the criteria that I showed on the last slide. So now theoretically, 100% of those people should be referred for genetic testing for Lynch, but what she found was that of the patients with the highest risk, meaning they have at least two or more criteria for Lynch syndrome, only 11% were referred for genetic testing. So that's 90% theoretically should have gotten tested that did not. Okay, and if you look at the number that actually undergone testing, it's even a worse situation, only 7%. So we're missing a huge number of the patients that are at risk for Lynch syndrome that are not undergoing appropriate testing. And so this is the reason why 95% of people with Lynch syndrome don't know it. So in this particular study, Dr. Kupfer wanted to look at racial disparities in this population, but her numbers were simply not enough. So she undertook another study. And this one was a retrospective study. She took patients from four different academic medical centers, about 800 colon cancers. Of these 800 colon cancers that came from this racial distribution, about half white, about a quarter black, the remainder split between Hispanics and Asians. About 90% of these tumors were tested for Lynch. 14% of these tumors had abnormal Lynch tests. So again, if you have an abnormal Lynch tumor test, you need to then move to the confirmatory testing with the genetic counselors. Okay, and importantly, this was 14% in all the different ethnic minorities, consistent with what we know, which is that Lynch syndrome itself does not really vary between different ethnic backgrounds. Okay, and so of these 14%, they then tested how they then looked in the charts to see how many actually got referred for and actually underwent genetic testing by different ethnic groups. And so she found that about 60% of these patients, again, theoretically 100% should have been referred for genetic testing. She found that 60% of whites were, whereas only 54% of African Americans were, and shockingly only 7% of Hispanics were. If she then went down to those that actually, after getting a referral for genetic testing, who actually underwent genetic testing, 10% of whites did, 6% of African Americans, and only 3% of Hispanics. So there's two issues here. Again, theoretically, all these numbers should be 100%. So we're having a huge amount of dropout between patients who actually need to get tested for Lynch syndrome and those that actually are getting tested for Lynch syndrome. And second, that there are racial disparities in that, for African Americans and Hispanics, they are not getting appropriate testing as frequently as whites. Okay, so basically, it's a terrible situation to begin with, and even worse for African Americans and Hispanics. So just with the last couple of slides, what is UT Southwestern doing to address these racial disparities in Lynch syndrome? So I want to highlight the very important work of the Genetics and Hereditary Cancers group at the Simmons Center here. So this is where the genetics counselors live. They competed for and received a grant from CPRIT, which is a cancer funding mechanism in Texas. It was called the Dual Grant for detecting unaffected individuals with Lynch syndrome, in which they wanted to use technology to streamline the process of identifying people that are at risk for Lynch and getting them appropriate genetic testing, and if they're positive, getting them appropriate medical care afterwards. And so what they did is they incorporated into our EMR, our electronic medical record, a series of screener questions that basically ask whether or not there is a personal or family history of early colorectal or endometrial cancer, or a severe history of this. And if any of these questions were positive, then that would meet criteria for an evaluation for Lynch syndrome. And that tagged these patients in the EMR so that we can ensure that all those patients were being referred for and receiving the appropriate care. Okay. And it was very successful. During the period of the grant, they screened about 20,000 people for this. There was an overall positivity rate about 3%. This was the demographics of the screened population perfectly mirrored the demographics of our of DFW, which is about half white, about a third Hispanic, about 15% Black, and the rest Asian. And this effort continues beyond the end of the grant, which was 2 years ago. And they've actually found a very large number of cancer mutations. So here they're looking for Lynch mutations. They found a large number of Lynch mutations. They also found mutations in a variety of other cancer risk genes. So this effort is ongoing, and we have additional efforts to make this process even more efficient. So here at UT Southwestern, if you are at risk for Lynch, that will get you the appropriate care, and that's done in a way that should be equitably available across demographics. So final slide, the things to remember: get colon cancer screening at age 45. If you have a personal or family history of colon or endometrial cancer, ask your doctor about Lynch syndrome. And unfortunately, racial and ethnic disparities in colon cancer are still at play in Texas. So just one more slide. I worry that I may have created worry in some of the audience. Worries like, do I have a hereditary cancer syndrome? So we're here for you, UT Southwestern, and so there's a very easy way to screen yourself or to screen family members if this is an issue. This is again from the Genetics and Hereditary Cancers group at UT Southwestern. This is the genetics counselors. They have an online quiz that you can take for yourself to see if you're at risk for Lynch syndrome or another hereditary cancer syndrome. And so with that, I will stop. I'm sorry I went over, and I'm happy to take any questions.
Thank you both so much for those presentations. It was incredibly informative. I'm going to start actually by addressing some questions in the chat. So our first question: how much research is done on differences in diet? For instance, how significant is living in a food desert with the prevalence of fast food restaurants or fried food and the lack of fresh produce?
So I would say that the population science group is very interested in those sorts of questions. There is already published data that that in areas of prolonged poverty, which are the same areas that in which there's poor access to healthy foods, that there are more severe cancer disparities. So this is an area of very active research, and I think it's an extremely important issue.
Thank you. Another question from the chat: what does history of mean? So for example, one person had the disease, does that constitute history of if they had it prior? Or would that be maybe someone in their family?
So it depends on the disease, but generally for cancer, if you have ever had a cancer, then for the rest of your life, you have that history. And the same thing with these hereditary syndromes. If you have ever had it, you have a history of it forever.
Thank you. I have a question that was submitted ahead of time for Dr. Nwachukwu. This person who's asking the question is a breast cancer survivor, particularly triple negative. And she asks, why are women of color more likely to be diagnosed with triple negative than white women? What research is being done on that?
It's a really good question. And to be honest, I'm going to give you the punchline is that we don't know the answer to why specifically they're diagnosed with triple negative breast cancers. What we do know now is that there is a higher prevalence or higher incidence of triple negative breast cancers in African-American patients. What we're doing now, as I showed in one of the slides, is that we don't understand quite the genetic diversity or the genomic diversity in minority populations. And so we're trying to essentially study the genetics of these patients so that we can figure out what are the genes or genes that are responsible for triple negative breast cancers, for example. So the answer is we don't know yet, but we're actively doing studies to try and figure this out.
Thank you. Our next question is actually from a healthcare provider, and they ask, how do I identify research studies that my patients might qualify for? And I think either of you might be able to to take this one.
So if you, yes, sorry, let me look through my notes. So there is a, so if you Google UT Southwestern and clinical trials, you will bring up the study finder. And so that is an easy online way to find what studies are ongoing at UT Southwestern. Sorry, I'm looking through my notes. I think I have the website. Well, maybe in the chat they can put the link to that website.
Okay, I'm sure we have a lot of colleagues from Simmons that are on the line right now, so they might be looking into that for us. So once we have that, we will put it into the chat. Someone asks, is there research or existing data about the survival rates of various treatments broken down by race?
Can you ask the question one more time?
So they're basically asking about, rather than just general survival rates, they're wondering if it's broken down by specific treatments by race.
I think there in certain cancers that data is available. One particular cancer type that data is available is in prostate cancer. I don't know that it's available in every cancer, but there is some data in prostate cancer with regards to what sorts of treatments are offered to patients, and that is done by race or by race and ethnicity. And that data has shown that there's a particular type of treatment called brachytherapy that's used in prostate cancers. In that particular study, and I'm not on that study, but from what I remember is that a lower percentage of patients or minority patients are offered brachytherapy, and that is there's a direct correlation with that and increased mortality in prostate cancer patients. But I don't know off the top of my head if that's a general thing for all cancers, or if that's been looked at in every cancer subtype.
It's helpful to know that it does exist for prostate, though. This next question is for Dr. Engelking. Do these types of Lynch cancers require different treatment from others?
So actually, the good news is that the Lynch colon cancers, at least, tend to be more responsive to certain chemotherapies. So you certainly, you wouldn't want to get a cancer, but actually for Lynch colon cancers compared to, for example, sporadic colon cancers, it's actually a little bit better in terms of with respect to chemotherapy. So the answer is sometimes.
Thank you. My last question, we're just going to go over 1 or 2 minutes, but it's from an educator, and they're asking, how can I increase awareness with my students and their families? How can we advocate for better care in all communities?
One thing, so an answer to, at least a partial answer to that, there's one additional program from the Simmons Center that I'd like to highlight, and that's from the Program for Community Outreach, Engagement, and Equity. So that'd be another link that if someone can pop it in there, that would be terrific. So the goal of this office is for bidirectional communication with the community about all aspects of cancer care. And they have 3 programs in particular, which are excellent avenues to get involved and get engaged to help with educating our communities across the DFW area about many different aspects of cancer care. And that's the Community Advisory Board, the Patient Family Advisory Council, and the Research Advocacy Program. So those are all things that you can check out online.
Again, a huge thank you to Dr. Nwachukwu and Dr. Engelking for an enlightening conversation on the necessity of diversity and inclusion in cancer research. Thanks to Joya and Jenny for helping run tonight's event, and thanks to our colleagues at Simmons Comprehensive Cancer Center for all of their help with this evening's program. Join us next month on Thursday, May 19th, for our next Science Cafe episode on the link between hypertension and Alzheimer's. See the link Joya is pasting into the chat to register. On behalf of our faculty speakers and the Science Cafe team, as we close out this evening, we wish you all good health and wellness and a good night. Thanks again for joining us. We are adjourned.